Thank you so much, everyone. I'll try to be succinct in my presentation, which is not always easy to do with a report so large, but I'm pleased to present the highlights from our statistical report named A Decade and Beyond, Perinatal Health in Ontario, examining perinatal care over the past 12 years. So over time, Ontario has experienced considerable change, and we've attempted to put historical and current context to the outcomes that we examined. This resource supports improved care outcomes through data-driven insights, and it contains descriptive statistics. So of note, we did not do correlational analyses, and we recognize that the information is meant to be generating hunches for, to where we could potentially do a deeper dive in the future. We begin by acknowledging the traditional territories where our data was collected. And I would like to recognize that many of you here today were important in making this data available so that we could conduct the analysis and write this report. Thank you for all of your commitment to the strength of Bourne's reach, and a special thanks to the core team who conducted the analysis and led the writing of the report. I won't name everyone because I only have a few minutes to present, but certainly thank you, everyone. And there's more information on the core team on page 13. Also of note, I did not include the highlights from the PSO and Carter deliverables because in those reporting products, they've been produced elsewhere, but they are in the main area of the report. I'm just not presenting on them today with the time that I have. So for context setting, as you know, Ontario is a geographically vast province with 40% approximately of Canada's population, and over 90% of the population resides in the southern part of the province. Birth volumes vary year over year, as many of us are aware, and currently there are between 140,000 and 144,000 annually. In recognition of the data that we currently have and the analysis that we've produced, we recognize that there are many pregnancies that we aren't able to capture in this report, with pregnancy loss not being captured in a healthcare setting, often occurs at home, and that could be up to 20% of additional pregnancies that we don't have here. In 2023 and 24, there were 88 hospitals providing labor and birth services, 52 NICU and NICUs, 92 midwifery practice groups, 3 independent birthing centers, all contributing information into this report. Healthcare is managed by 6 Ontario Health regions, and they were kind enough to share this wonderful mapping that you see here today as a result of AMU's relationship there. So thank you, AMU. And we also recognize that there are now 19 fertility clinics distributing data nationally. So of the births that have occurred, obstetricians attended 82.2% of births during the reporting period. Family physician involvement declined from 8.7% to 5.1%, while midwife attended births rose from 8.5% to 11%. There, of course, were some care transitions between midwifery at the time of birth. So we did see an increase in midwifery care, not just at the attendee who was there for the birth. And it went from 12.8% in 2012 to 19.7% in 2023-24. The birth volumes have been stable, but the demographics are certainly shifting in how we are seeing individuals coming into pregnancy and what's happening overall. So we'll go into that in a little bit more detail. I think we need to recognize that there are limitations associated with the data that we currently capture, and there's an entire section in the report on notes for interpretation and in recognition of the language that we currently use, the data that we're capturing on race and Indigenous data governance, and some social determinants of health. Since many of you, since this is an entirely internal presentation, I won't go into it in detail. The health equity team has presented on it regularly, and we are a bit tight on time. And I don't have the time to present on some of these outcomes related to the data that we have based on race or the Ontario Marginalization Index. So I'll just keep this succinct to say that the report does contain additional information here. And in the broader webinar, I'll go into it in more detail and certainly discuss this a little bit further, but just recognizing the way that we currently capture information and how we present on it going forward. But I was given 20 minutes. So key highlights. First, I think it would be important for us to discuss maternal and pregnant individual risks. The first shift that we observed over the course of the study from 2012-2013 to 2023-24 is that pregnancies today begin from a more medically complex starting point. In this figure, each of the colors represents an age group, with the green, blue, and dark green representing women and individuals 30 years of age and older. In 2023-24, nearly 70% of births were to individuals age 30 or older, which is up from 57% in 2012 and 2013. We are also seeing that increased maternal age is also associated with higher risks of pregnancy complications and fertility challenges and genetic risks, which we've seen from other work that we do in the fertility bundle. So in addition to the shifts in maternal age, we see a significant rise in individuals entering pregnancy with chronic conditions, which demands more interdisciplinary complex care models. The prevalence of pre-existing health conditions has risen dramatically from 17% in 2012-2013 to 25.6% in 2023-24. Individuals living with obesity now exceed 21% of the pregnant population, and in 2023-24, 58% of singleton pregnancies resulted in excessive gestational weight gain. Excessive gestational weight gain increases the odds of gestational diabetes, hypertension, and cesarean delivery. Obesity is a complex issue, but the trends are clear. Our pre-pregnancy BMI is rising, and the majority of pregnant individuals are gaining more weight than is recommended. This has lifelong implications for both the mother and the infant, including risks for gestational age babies. And I will recognize, I think, which is something I should have addressed at the very beginning, and that is that there are changes in the way that we do capture data. And I think it's important for us to recognize that upfront, that some shifts that we might see could be a result of data quality issues, but some of it is certainly a result of shifts in the changing population. And when it came to this particular information, we evaluated it numerous times because we were surprised with the outcome. So from an analytical perspective, we looked at it and we looked at it and we looked at it again to make sure that the conclusions that we were making were accurate and reflective of what we were seeing in the data. The prevalence of hypertensive disorders during pregnancy has increased from 5.9% to 7.9%. Gestational hypertension, preeclampsia, eclampsia, and HELLP syndrome have all seen increases. And these concerning trends are likely indicative of the increases in the complexity of who's coming into pregnancy, and they demonstrate a need for heightened awareness, early detection, and effective management during pregnancy. The rise in maternal age and pre-pregnancy BMI is mirrored by a notable increase in hypertensive disorders and gestational diabetes. For gestational diabetes in general, we've seen nearly a doubling. You'll see here the colors on the right-hand side indicate age, so it should be obvious from a figure perspective, but the dotted line in the center shows the overall mean. And the overall mean has increased from 5.2% to 10% overall. Diabetes poses risks for macrosomia, which can increase the risk of birth injuries, including shoulder dystocia, preterm birth, higher risk of cesarean delivery, or stillbirth, creating new challenges for care management. And as the prevalence of diabetes continues to grow, these findings emphasize the importance of early detection before and during pregnancy. So when we present this externally to health administrators and planners, I think that we need to recognize that increased resources are necessary, and there may need to be a shift in the way that care provision is available. The next section that we looked at a bit more briefly here is on mental health and substance use. And this was one of the most striking trends that we saw in the 12-year history, that mental health concerns in pregnancies had nearly doubled, with 1 in 5 individuals reporting a mental health concern. In this particular figure, we've captured anxiety, depression, and any mental health consideration and mental health concern. And I think some literature suggests that these conditions may affect parent-infant attachment and newborn development. So we need to ensure that regular screening during prenatal visits is included. And as part of the work that I do with the Perinatal Death Review Committee Board, there certainly have been recommendations that in our new Digital Ontario Perinatal Record that we do capture better screening and more frequent screening to help address these concerns for pregnant individuals and in the postpartum period. While the decline in smoking is a major public health victory, dropping from 11.2% to 5%, the rise in cannabis use is concerning. We recognize that the way that the data is captured may have an impact on the way that it's reported. In this particular case, we recognize that there are some data capture issues, but we also recognize that with the legalization of cannabis, there's a reduction in stigma and reporting, particularly related to child protective services. And there's some work that's been done by Dr. Daniel Corsi, and that's been gone above and beyond what we are seeing from a data quality capture perspective in the born data. So we do still see an increase in cannabis consumption overall, at least from a reporting perspective. And while cannabis legalization has been had an impact on these overall impacts, there are certainly misconceptions related to the safety of cannabis for fetal development. And Dr. Corsi has actually seen in the past that it is in fact associated with preterm birth, low birth weight, and small for gestational age infants. In our next section, we'll look here at overall substance use. So while the prevalence of substance use has seen a decline, we recognize that this particular decline is predominantly driven by the decrease in smoking and may in fact be misleading, given the lack of vaping data that we currently have, as many individuals who are supporting patients with a transition off of smoking, many of them are moving into vaping products, which for nicotine, access to nicotine. And in that case, we are not capturing it. So there is some, I would say, there are limitations to the way that we should interpret this particular figure. In this particular figure, though, any substance use in pregnancy does include cannabis, alcohol, smoking, the use of illicit drugs during pregnancy, including opioids, cocaine, etc. And among individuals using substances in pregnancy, 64% of those under the age of 20 reported a mental health concern. The way that we've analyzed the mental health concerns, and there are more details in the report that you can look at with respect to the technical notes and the numerator and denominator if you want to do a deeper dive. But those that we've captured here include addiction, anxiety, bipolar disorder, depression, a history of postpartum depression, schizophrenia, and others. Next, we'll discuss briefly some highlights from the labor and delivery trends. So while reviewing these images side by side, I think it's important to note that the y-axis values are different. This is because the way that the images were displayed in the report, and we will fix it going forward for the webinar. But recognizing that on the left-hand side, the y-axis has a max of 70%, and on the right-hand side, it's a max of 45%. In this figure, we're looking at the distribution of gestational age among births. On the left-hand side, it's among live births, and on the right-hand side, it's among stillbirths. We see on the left-hand side an increasing birth rates in the late preterm and early term periods, with a reduction in late term birth, which suggests higher rate of intervention to bring about the birth. However, the corresponding decline in stillbirth rates at these gestational ages may be attributable to the effectiveness of earlier clinical interventions aimed at preventing fetal death. There has been a profound shift away from spontaneous labor overall. So medical induction is now a key factor in 1/3 of all births, which fundamentally alters the experience and management of labor in Ontario. This particular figure, you can see that across the top is spontaneous labor and how it's shrinking over the course of time, and the impact of induction of labor, which has been increasing. I'll move on to the next section, and then the no labor is at the bottom. When we decided to do a deeper dive into indications for induction, so we've seen these shifts, but why? Why are we seeing these shifts in labor? We looked here at the indications for induction. So we do see a shift in rationale over the course of time, with a 20% decline in rationale for post dates, which is quite significant. So you'll see in the center of the figure here a large drop from 2012 to 2024, and that is the post dates conversation, because many of these births are not making it to post dates. We also see shifts in diabetes, which we previously discussed briefly, but certainly it's doubled or nearly doubled from 2012 to 2024. And maternal request has nearly tripled, so from 4.1% to 11.3% overall. And increasing cesarean birth it has been seen across the board here. So key indicators for cesarean birth were a previous cesarean section, atypical fetal surveillance, and non-progressive labor. We do recognize that cesarean birth has increased from 27.4% to 33%. And while it's consistent with the Canadian trend, 1 in 3 is certainly a notable amount of births that requires a deeper dive into understanding who and why and what can be done about it. Of the 33% with a previous cesarean section, nearly 60% of them were eligible for VBAC, so vaginal birth after cesarean section, but only 30% attempted one. Now, the good news is that of those who attempted a VBAC, 70% were successful. And we recognize that there are many perceived and actual barriers to supporting pregnant individuals in attempting a VBAC. We believe that, it's certainly important to access resources that are available from the Society of Obstetricians and Gynecology, the AOM, and PCMCH, who also has additional resource documents. And they summarize the evidence in a way that should be more readily accessed for shared decision making. And certainly, while we see this shift, I think we do recognize that it may be time to do a deeper dive to see where we may be able to influence and safely reduce cesarean section, in particular patient populations where appropriate. This particular figure is a deeper dive on the Robson groups, because when we were presenting this more globally, we thought it would be important to, look at the different groups to see who, in fact, we could be influencing in a way that we may be able to make a notable difference. So we saw increases in nearly all Robson groups for cesarean rates overall. In particular, group 5, group 2, and group 1, we've decided to highlight. So I'm not sure if the figure is too small to see on that size screen, but group 5 is the multip singleton cephalic term with a previous cesarean section. And the group 2 is the nullip singleton cephalic term with induced labor or cesarean before birth. And the group 1 is nullip singleton cephalic term and spontaneous labor. So these particular groups we've pulled out in particular because they highlight opportunities to reduce unnecessary procedures through VBAC promotion and limiting elective inductions and improving induction methodology overall. Of the 75% of laboring individuals and I apologize, I haven't slept much since yesterday, but 75% of individuals used pharmacological pain relief throughout the reporting period, which rising above 83% across all levels of care. So level 1 and level 3, you can see this figure here across the board where you can see all of the different levels of care. Level 1 and level 3 hospitals saw a temporary dip during the COVID window, most likely. It was during the COVID window, but most likely due to the practice changes during COVID. An epidural in labor is the most predominant type of pain relief used in all level of care settings. Here we highlight infant outcomes and neonatal morbidity and mortality. Stillbirth rates have remained consistent over the past 12 years, and they varied between 4.5 to 4.9 per 1,000 births. So we have not seen a notable shift. There is a national mandate to do a deeper dive into stillbirth overall. And while we haven't seen a significant shift, certainly, the goal would be to reduce the rate of stillbirth overall. And some of the team members here are doing some research specifically into stillbirth outcomes, including COSM. So I'm sure we'll see more to this in the future. Most infants in Ontario are born full-term and healthy, but our high-risk numbers remain consistent. Preterm birth is a major driver of NICU admission and a leading cause of neonatal morbidity and mortality. Preventing preterm birth is essential to improving infant survival and reducing long-term health complications. It has remained relatively stable over time. So in 2023-24, the prevalence of preterm birth was 8.5%, representing about just under 12,000 newborns. Not shown here, but based on other ongoing work, the rate of newborns born out of scope or in hospitals unequipped for their gestational age and care needs has seen a decline. It has decreased to 18.7% of deliveries at less than 28 weeks, which is down from 30% in 2012-2013. And that's a good news story overall. Certainly, we've seen a shift in hospitals changing their level of care, which has had an influence, particularly in the Toronto region, which has a large volume of births. But we are doing a deeper dive on that particular work, and stay tuned for an upcoming report. Complications in pregnancy. So we see increases not only in pre-existing health conditions, but also in complications of pregnancy. Premature rupture of membranes, inclusive of the preterm group, has increased from 5.1% to 6.7%. As well, intrauterine growth restriction has nearly doubled from 2.4% to 4.3% over the course of the review. And average NICU stay for all neonates was 11.1 days. Of course, infants born at an earlier gestational age require access and care in a NICU for a longer duration. And newborns born between 20 to 24 weeks rose from 61.7 days to 82.3 days. And that's recognizing that there are practice changes in this particular age group where life-saving attempts are being made for extremely preterm infants. In fact, I was at the Canadian Neonatal Network meeting this week, and some centers are migrating to include infants born under 22 weeks, if they're 21 and several days. In fact, a few centers are performing life-saving activities if they felt that they were closer to 22 weeks and they couldn't be certain. Newborns admitted to the NICU with a normal body temperature reflects the effectiveness of immediate post-birth care, and is essential to prevent complications like respiratory distress and metabolic issues. Not shown in this particular image, but we have seen an improvement in normal body temperature at first admission. It's improved from 75% of NICU admissions to 77.7%, nearly 78%. Neonatal mortality has declined from 0.29% to 0.25%, which represents 365 deaths in our most recent year. The decline in neonatal deaths does reflect medical advances and improved care. Newborn feeding and postpartum. So we have a paradox in Ontario. Almost everyone starts breastfeeding with initiation at 92%, but fewer people are continuing to exclusively breastfeed by the time that they leave the hospital. And we've seen a decline from 58.5% to 43.3%. Medical supplementation rose from 4.2% to 15.5%, and it lowers the adjusted breastfeeding rate below the baby-friendly initiative, which is a target of 75%. In fact, at CNN, one of the leading outcomes that they're looking to capture is exclusive breastfeeding, even for individuals who are in NICU care, and that's an area that they're planning to focus on in the upcoming strategic priorities for their group. Generally, this information highlights the need for stronger early lactation support, including resources and education to assist individuals in overcoming common challenges in the early postpartum period. Of course, this is for individuals who choose to breastfeed. And we believe that there's, evidence-based supplementation practices and a broader implementation of the baby-friendly initiative would certainly have an impact overall here. As hospital stays shorten, so in general, we are seeing 28 hours for individuals with a vaginal birth and 45 hours for individuals with a cesarean birth. We are seeing, though, a corresponding rise in postpartum readmission. So we evaluated maternal postpartum readmission using data supplemented by CIHI, and we were only able to look at the last 2 years. So we have to recognize here this is not the last 12 years, and it's certainly something we could look at going forward if we can capture additional data from CIHI, which is a possibility. But just looking at the last 2 years, we still saw an increase in readmission up to 1.7%. The leading causes of readmission include postpartum hemorrhage, infection, preeclampsia, and hypertension. And postpartum hemorrhage increased from 1.0 to 1.4% in the last 12 years overall using our main data. And it is an area of focus, as many of you know, due to the discussions that we've had with respect to CANOS. We see an increase in maternal ICU transfer in labor, birth, or postpartum from 0.14% to 0.18%, representing 250 people in 2024. And of note, our prenatal care access has improved. So this declining trend is a good news story. It's actually the figure represents individuals with some who did not have access to a first trimester prenatal visit. So individuals had more access, but still, this figure shows that about 9,000 individuals are not able to access prenatal care. And disparities persist among marginalized and racialized newcomer populations, not shown here, but there is a growing concern that 8.1% of newborns cannot access a primary care provider, which is up from 3.5% in 2018-2019, leading to fragmented early assessments. Hospital births requiring greater than 100 kilometers of travel range from 0.2% to 28.6% between Ontario health regions. They remain stable in many areas, except in the Northeast, we've seen a notable increase from 9.3% to 13.6%. And in the Northwest, we've seen a slight increase. And we recognize that there have been hospitals have had a changing landscape with respect to closing labor and delivery access. And some of the work that DART's been doing separately is looking at conducting analyses on births that are happening in the North, where for centers who are trying to promote access to having those centers reopened for labor and delivery. But it's not shown in this figure. To summarize, certainly we are seeing additional complexity. We are seeing increased advanced maternal age, more interventions overall, an increasing need for mental health support, fewer spontaneous labors, greater medical intervention, and a shift in substance use. And in our review overall of our care population, we do see some highlighted wonderful areas of improvement, and many of those have been specific to access to midwifery care and a number of our newborn outcomes. We still see, you know, the information that I just went through, so I won't spend a lot of time on this slide, but we do still see some challenges with respect to readmission, maternal morbidity, and mortality, and breastfeeding overall. But I think that it's important for us to wrap up, and as Alicia said in the opening comments of the report, she said, you know, together let's use this report not just to reflect but to act. And I think it's important that we take this information, we translate this data into action. We presented it at MNOC just briefly, and they asked for a deeper dive into the information in a workshop format. We've been asked to produce grand rounds with some more granular information related to what could be done in the intrapartum period and beyond. And I think it's important to recognize that, you know, all of us here in this room have an opportunity to take the information, just even with it, you know, the way that we can currently interpret it, look at where we could be doing a deeper dive with many of our partners and share it more broadly so that centers feel that they are a part of the overall picture. They see what's happening in Ontario, and we recognize where there are gaps. So thank you, everyone.